Now, I shared your PowerPoints, but it is on PDF. Can you see your PowerPoints?
Yes, I can see that one.
Okay. You can try yourself. If you select the share screen and open your PowerPoints or your PDF on your desktop, you can share it easily.
It's not working from my side. There should be one point of a share your screen. It's not coming up for some reason. But can I, for some reason, I don't know why is it not coming. Can I move around with this one? Like if I have to go to the next page or next slide or something like that, I cannot. I don't think so. I can. No.
Okay, don't worry. I will change your pages with your speaking. Don't worry.
There were some videos. That was the whole concern was. Anyhow, so yeah, we can still navigate how we can do it. Let's see. Yes. There were some videos in it, so we will not be able to go with those through videos. You know, there were some fancy videos by Dr. Okison. I borrowed that video from him.
Okay, so just a moment. I will speak with our supporters. Amna,
Yes.
can we start the program?
Sure, we can. I was just
Okay.
trying to work with the, if still we can bring the, PowerPoint, it's not working anyhow. So sure, we can start the
okay.
program.
Dear audience, dear students, colleagues, and professors, welcome to the webinar. First of all, I would like to introduce our valued respected colleague, Dr. Amna Hasan. She is a clinical assistant professor, East Carolina University School of Dental Medicine, and she is clinical supervisor of AEGD and GPR residents in Orofacial Pain Clinic. She is also a lecturer on temporomandibular disease and orofacial pain and dental sleep medicine for AEGD and GPR residents. Dr. Hasan, thank you very much for accepting our invitation to talk about temporomandibular disorders. We are pleased to listen to you. The stage is yours.
Thank you. Thank you for inviting me to speak about temporomandibular joint disorders. And my pleasure to be here talking about, and my passion is about orofacial pain and specifically temporomandibular joint disorders. So this is a picture. The first picture is of these beautiful horses and this farm at the Lexington, Kentucky in USA. And I did my residency with Dr. Occlusion at the University of Kentucky. And this picture always reminds me of that place. When I started my residency and the first lecture Dr. Occlusion gave, he gave all the background about how to, which horse has won the races and how much they have made money. And I was sitting over there and just listening to his lecture, and I thought, Amna, what are you doing over here listening about horses? And you came over here to do your orofacial pain program. And I asked Dr. Occlusion, why do you give this lecture, Dr. Occlusion, and talking about this horse has made so millions of dollars, and I'm just a resident over here. He said, Amna, you have so much of brain and you want to do something good. And that's why you are here. I'm just want to see how many of people, just want to make money, and how many of you are so devoted to your profession. So that's always a reminder for me to be humble and to work towards my goal, which is to serve for orofacial pain. Next slide, please. I cannot, Mariam, can you move the next slide? Yes. So a lot of patients, when they come to me, they will say, oh, I have a TMJ. Even the physicians who will refer the patient to me, the patient have TMJ. We all have TMJ. As a dentist, we know that's a joint, Tmj joint. But I teach my students, my residents, that it's TMD, temporomandibular, or we can say TMJD, temporomandibular joint disorder. We never say TMJ. As a dentist, background with a dentist, we teach the right terminology to our students, our residents, that it should be said as TMD, not TMJ. That's my first thing. I always tell them, never say TMJ. It's a joint. Everybody has that joint. Even I give that information to my patients as well. Yes, everybody has TMJ. You have TMD. Next slide, please. So temporomandibular disorder, it's a very bigger terminology. It's a group of musculoskeletal, both muscular and skeleton component, and neuromuscular condition, and that involve the TMJ, the joint itself, the muscles which support this TMJ joint, and muscles beyond that as well. So masticatory muscles and the associated tissues like the ligaments, which support this joint. Sometimes the muscles beyond the masticatory system as well, like the muscles of the head and neck region. That also, when they are painful, that also can cause temporomandibular disorders. So if we go and look into Dr. Occluson's classification, in his Bell's book. And then there is a very huge classification. We cannot cover that classification and talk about all the disorder in 1 hour, 1 or 2 hours. So today we are just discussing the basics ones, you know, when the patient comes into the clinic, what is the basic things they talk about. So we will just go through the superficial of those basic main disorders, TMD disorders. We will just discuss about those ones today. Next ones, please. So for the basic one, I will divide these temporomandibular disorders into 2 groups. Intracapsular is the one which is the joint itself. That is the capsular one, intracapsular. And the one is the extracapsular. Extracapsular is the one where it's a muscular component. That is our masticatory muscles. So when we say the patient comes with, oh, I have a TMJ, or we one sometimes thinks the most common cause of the TMD issue is the joint itself. No, it's not the joint. It's the most common cause is the muscle. The patient, there were so many studies done. The most common cause of TMD issue is the muscles, not the joint. So we will discuss 2 of them, intracapsular and the extracapsular. But the extracapsular has so many components in it because it is, some of them are not painful. So in the patient has that clicking, popping, different kind of noises, but they are not painful sometimes. The patient say, oh, it's there, but you know, it's not bothering me. Or sometimes they come to us with, they say, oh, I hear these noises. So sometimes we do not take care of them, but the major component of pain is usually the muscle pain, the reason why the patient is there. So when we say temporomandibular disorders, muscle pain is the most common cause of pain in this region. Next, please. So the most common cause why the patient is worried is the sounds, popping, clicking. So the parents, our pediatric patients, the parents come to us because they are worried. Oh, my kid is having this unusual noise in their joints. They are having a clicking. They are having this popping, even though these clicking and poppings are not painful. I also get a clicking and popping on my right side of my TMJ, but it is not bothering me. But it's sometimes I'd say, yes, it's a TMD. Yes, it is a condition, but it is not painful. So we do not take care of it right now. If it is not painful, we leave it like this because even we do an MRI or CT scan on it, the treatment is not going to change. The etiology, whatever the etiology, if we know it, we can take care of that one. So it is not getting locked, but we do not go beyond that at this time. Next slide, please. So I call it a Tmj Symphony. So a musical symphony. So it's a clicking and popping, which is usually seen in disc derangement. In short, we call it disc derangement. What's happening with the disc, we don't know at that time because the disc is being displaced, but it is getting reduced. Then we have this thud, dull thud, loud thud, that is hypermobility of the joint. Then we have this crackling noises, the crunchy noises the patient will say. We call it Crepitus, and that is the degenerative joint disease. So I call it symphony of musical symphony for our TMJ joint. That's an easy way of remembering these things I tell my students. So I cannot see the whole screen, Mariam. Can you reduce it a little bit? The last lines I cannot see. Reduce it, minimize it a little bit.
Is it okay, Amna?
This one is okay. The next one was, I couldn't see the...
Yes. Is it okay?
Yes, that's fine. This one is fine. Okay. So in the first picture, if you look at it, this one is the, if you look at, this is the mandibular condyle. This is our condyle. We all know about it. It fits into the mandibular fossa, and in between these two bones is the disc. And all three of them make a compound joint. So compound joint is when we have at least 3 bones. Despite these are not the 3 bones, but we consider this disc as to be the 3rd bone, and it's actually not a 3rd bone, but it's still considered as the compound joint. So what happens is the collateral ligaments, which supports this joint or keeps this disc in place, those ligaments, they become elongated because of different reasons, because of the trauma. Trauma, as simple as trauma can be micro trauma, like clenching and grinding of the teeth. Trauma can be macro trauma, like you have a blow to your face. So there can be different reasons of the trauma. So that trauma can result in the elongation of these ligaments, which support our TMJ joint, resulting in the disc being moved from its original place, and the disc and condyle are no longer articulating. As we looked into this picture, the disc has come in front of the condyle. Along with that, what's happening is if you look at these retrodiscal area tissues, which has all the blood supply and nerve supply, they come in between these 2 bones. Sometimes what happens is when the joint is being moving around, the patient might have that clicking and popping. They say it is painful. That's the reason the patient is having pain when they are having that clicking and popping. Some of them they do not have pain. Some of them, they do have pain. Next slide, please. So this is the disc has been displaced now. So this is the closed mouth position. As we know, this joint makes 2 different kind of movements. First is the hinge opening, that is the rotation. The joint first rotates and the disc is being displaced. The disc is in front. And then when it is gliding, or we say sliding down, the disc is being reduced. So it jumps over the condyle and goes back. So it is jump over the condyle and it goes back. When it is jumping over the condyle and goes back, it makes a sound of a click. So then it's when we are listening that sound of clicking or popping. Sometimes it is very loud. This clicking and popping can be only during opening. It can be only during closing. Sometimes it is both during opening and closing. Then we call it reciprocal click. It can be painful, it cannot be painful. So you can move this slide, and I don't think so we can see this video. That was my whole aim for this. We will not be able to see this video. So now what happens is some patient will come to you, okay, after this, they will come to you and say, doctor, now I used to have a clicking and popping going on in the right side, and I do not have hearing this clicking and popping, and I cannot open my mouth wide. And they have a locked jaw. So what's happening? These ligaments, they become more elongated. Because of the superior retrodiscal lamina, they lose their elasticity, and they also become elongated. And recapturing of this disc becomes more difficult. Sometimes it gets, and sometimes they have a catching sensation, and finally it becomes more difficult for them to recapture it. And when they are having that rotation, the disc is further displaced. And when it is further displaced, when they are trying to slide or gliding, there is no click. The click stops because the disc is not being recaptured. And the patient having a locked jaw. And the patient is open roughly around 23, 24, 25 mm. The normal range of motion, according to our literature, should be 40 mm, close to 40 mm. I will not say everybody should have a 40 mm, depending upon if the patient is very petite. Some females are very petite. We say, okay, it can be around 38 mm. Some of our younger patients, I have seen 70 mm in one of my students when we were doing a lab work on them. 70 mm is, I said, okay, maybe it is hypermobility of their joint, but no, that was normal for that patient or my student. So if we go according to our literature, it is 40 mm. So that patient, if they are 23, 24, 25 mm, cannot had a history of popping in the past, and now the popping stops and they cannot open wide, they are in so much pain. So you know that, and when they're trying to open, their jaw moves towards the affected side. So that means they are locked, and it is the disc is not being recaptured, and it is called disc displacement without reduction. Next, please. So this was the video. The next kind of our symphony is called the third, this subluxation, or we call hypermobility of the joint. So some of our patients do not have the smooth anatomy, or we will say they have a unique anatomy. You know, what happens is they can open wide. Like I told one of my students can open 70 mm, but it was a normal anatomy for him. It was not unusual anatomy that they have a, you know, their eminence was had an unusual anatomy. So what happens is near the maximum openings, these patients make an unusual noise. We call it thud. It's a dull thud. It's not pop or clicking. So these patients have their eminence is in a unique way. In the posterior slope of their eminence, they are very short and steep. Along with that, they have a long and flat interior slope of their eminence. So what happens is their condyle comes in front of the eminence, and that makes a noise. That is very dull thud noise. And for those patients, they get sometimes little catching sensation because they come in front of the eminence as well. And they get really scared. And we tell them, okay, you know, it's better not to open wide. If you open wide, again, because you are stretching or elongating your ligaments. I will not use the word stretching. Stretching is like a rubber band. We stretch the rubber band and rubber band comes back to its position. But the ligaments, they elongate. If they get elongated, they stay in the elongated position. They do not go back to their normal position. So we tell them, you know, do not open wide. Then there will be no sound. And if you keep on opening your mouth too wide, like yawning and all those things, and obviously they're going to yawn. We tell them to muff your yawning, put your hand over there, do not open too wide when you come to your maximum opening. And because there is high chances your ligaments can elongate, and there is high chances that you're starting having clicking and popping as well, along with this noise when you open all the way. So there are high chances of having this displacement as well, or derangement as well, along with this subluxation as well. So this was another video of the patient. You can clearly see in this patient, you know, when she was opening all the way, you can see the movement of her condyle. You can see its unusual place coming all the way. On the maximum opening, you can see the different movement of her TMJ. We see in hypermobility of the joint, some patients, you know, they have a funny bones. They can move their different joints in a different way. They can move their fingers a lot, their elbows in a different way. And ED syndrome, we call it. Those patients can have this hypermobility joints, and they have this subluxation a lot. This noise is a lot. Next, please. So there are two terminologies over here, subluxation and luxation. So, you know, subluxation is where, you know, they have this noise, but the patient can close the joint, come back and close it. They come in front of the, you know, eminence, then go back and close their mouth. But luxation is where the patient come in front of the eminence, but they cannot go back. They get stuck. They have an open mouth. That is, I will say, okay, when the patient comes, sometimes it's very difficult for them to describe. They have a closed lock or open jaw locked. Closed is not always a closed. It is usually the partial open locked. You know, they can open a little bit, not totally closed, shut down. So I always ask them, is it like partially you can open it, or it's like an alligator, you know, you open all the way and you got stuck. So this is that alligator, you know, open all the way and you get locked. So what happens in luxation is the disc condyle complex, they come in front of the eminence and get stuck over there. When it gets stuck over there, your jaw moves to the opposite side. So this is another indication you're locked. If it is stuck on the right side, your jaw moves towards the left side. So this is our patient who got locked on, this is a right side, yes, on the right side, and whose jaw moves to the contralateral side and moves towards the left side. So the best thing is to tell the patient, you know, if you get locked like this, they panic. You know, obviously everybody panics when they get locked. So they try to close it faster, and then they close it in front of the eminence. So we tell them, do not get panicked. The best thing is to try to open wide again, not close it. Open wide and try to put your fingers down here on your mandible, and try to push your mandible at the chin, you know, close to your chin, and try to push your mandible from here and try to close it that way. And usually we tell them on the phone, if they call you, you know, we tell our front desk are trained for that. We tell them, you know, they tell them, this is what you try doing it before coming over here. So as soon as they are in the office, then we try to do it. And we had some patient who had this kind of lock. That patient was, I remember that patient was in old age home. So it was locked for a month time, and they bring the patient to us, and they said, okay, this patient has been locked. It was bilaterally locked like this and dislocated, I will say. And then they wanted us to do in office this kind of procedure. I said, this is now too late because the muscles are in spasm so much. We cannot do it. That has to be done in the OR. Patient needs to be under anesthesia because the muscles are so much into spasms. They become so tight. At that point, it is very difficult in outpatient to reduce and put the jaw back into position. So our oral surgeon did it and, you know, take the patient into the OR, and they did it over there. Next slide, please. So the next sound is our Crepitus sound, the crunchy, nice, and crunchy, crackling noises, they say. And it's called osteoarthritis. It's a degenerative joint disease like any other kind of arthritic changes in any other joints. It's the same kind. There is cartilage degradation and the bone remodeling, subchondral bone remodeling, and synovial inflammation, and the patient is having chronic pain. As we know, osteoarthritis is a chronic pain condition, and it can be due to different reasons as well. Rheumatoid arthritis, there are different reasons for, for arthritis, but we will just stick with the osteoarthritis over here. The good thing about this joint is that that usually it does not require, I will say 90% of the chances, it does not require replacement of the joint, because the mother nature has made it in such a way that if we give a good environment to heal properly, if we do not abuse it, so it makes a reparative bone on top of it, and then the patient is not in pain. Usually the pain subsides in 1.5 years, and the patient then does not even realize it sometimes that he was in pain. But I will say we have to really babysit this joint like any other joint. And that's a good thing about this joint. I tell my patient, you know, if you take care of it, you will be pain-free after a year and a half. But if you're going to abuse it, not taking care of it, then it will become, you will have pain throughout your life. Most of your time, you will have pain. Next, please. So etiology is multifactorial. Sometimes the disc got displaced, so that we don't know where the disc is. Only MRI can tell us. And now there is just two bones stick together, and it's going to cause the destruction of these two bones. Then it can be secondary to some kind of trauma, parafunctional habit, if you're clenching, or joint loading, functional overload, joint loading, too much of loading, it is compressed, it is going to cause pain, changes in the joint, joint friction, certain developmental abnormalities. Along with that, it's not a true inflammatory response. It's a non-inflammatory condition. That's the reason we do not prescribe antibiotics to these patients who have osteoarthritis. And so it's usually we give them NSAIDs and to take care of the pain. So it's not a true inflammatory response. It's a non-inflammatory condition. And but there is changes in the bone, definitely some deterioration in the bone. Next. So what are the symptoms, clinical symptoms? The patient will complain about pain, pain in the TMJ joint, pain and stiffness in the joint. They have a difficulty opening wide. Functions of the joint, the TMJ joint functions are affected. They have a difficulty opening wide. They have a difficulty talking. They have a difficulty in chewing food. These are the basic function of the TMJ joint. Along with that, they hear some noises that can, we call it crepitus as a terminology for, as a dental terminology or medical terminology, we say crepitus. But the patient will say, I hear crunchy noises. It's like a bone-to-bone noises. One of my patients has a unique way of saying, it's like, you know, when you open a door and close the door, the hinges make the noises. That's the kind of noises I am hearing. But these symptoms are seen in a symptomatic patient. Then we have asymptomatic patient where there is no pain. Despite on radiograph, when we take a basic panoramic radiograph, we see patients having arthritic changes. We see it on their pan. That patient is having arthritic changes, but they do not have pain. It's similar to when we see MRI or CT reports on, specifically CT reports of the spine. A lot of patients have some arthritic changes on their spine, but they do not have back pain or anything going on. But a lot of patients, they have very mild changes in their spinal, in their CT reports, but they have severe back pain. So some patients will have pain and some will not have pain. Depending upon it is active, I will say, arthritic changes going on, or it is not an active arthritic changes going on. Next slide. So clinical presentation is the patient should have some kind of noises, crepitus sounds, limited mouth opening, and there should be some deviation when the patient opens the mouth, deviation. And when you palpate the TMJ joint, there should be some tenderness. Along with that, there should be some tenderness in the masticatory muscles as well. Usually the tenderness is seen in the masseter muscle. I will say usually, but it can be present in the temporalis muscles as well. So this is an interesting case for, this is our, I cannot see the pictures down here. Anyhow, this is a 45, these are the different clinical presentations. This is the occlusal changes seen in 3 different osteoarthritic patients. Yes, thank you. This is our 45, again, it's glass. This is our 45-year-old female. Okay, this is better. This patient, the first picture is of a 45-year-old female. She had a left Tmj osteoarthritis. When she had a left Tmj osteoarthritis, her mandibular midline, it shifts to the left side because of the changes in the TMJ joint. And the second one is a 56-year-old male. The patient has a bilateral Tmj osteoarthritis. Because of the changes in both the TMJ joints, the patient is having anterior open bite. If you look at that, there is anterior open bite in this patient. And the third one is 57-year-old female with the right Tmj osteoarthritis. So this patient has a right Tmj osteoarthritis. So resulting in the left side is the posterior open bite. So these arthritic changes can bring changes in the bite. So as a dentist, we are so obsessed with the bite, so obsessed with the occlusion. Sometimes we say, okay, patient has a TMD issues because of their bite, the changes in the bite. But we never think, say, okay, you know, because of their TMD issues, there can be changes in the bite, you know. It is not that bite can cause TMD. It can be that the TMD issues can cause bite changes. So this is the bite changes because of their TMD, their arthritic changes is causing, or TMD issues are causing the bite changes in these patients. Next, please. So according to American Academy of Orofacial Pain, how we diagnose our osteoarthritis. They say, according to history, the patient should complain about pain. Along with that, patient should complain about noises, hearing some noises. And according to our organization, we say when we are doing the examination, the patient should have pain at least one when we are palpating the TMJ joint, the lateral poles of the TMJ joint, or during when we doing the jaw movement, telling the patient to open, close, move the lateral excursions, or during that time they should be having a pain. Another thing, or they should have some joint noises, crepitus, detected when the patient is moving the TMJ joint, or the patient should have reported crunchy, grinding, or grating during the exam, or patient should have reported it. Along with that, we have seen some kind of abnormalities or changes in their TMJ joint on CT scan. Then we say, okay, this patient has some arthritic changes, or we diagnose the patient with osteoarthritis. Next slide, please. Okay, so patient is here. Patient just complained about joint noises, no pain. On examination, you did not find any kind of pain, but during your examination, you found some noises, crepitus, detecting during movement. Patient also said, okay, you know, when I was moving, you were examining. There was some crunchiness, grinding. And on the CT scan also, you found some arthritic changes in the TMJ joint. Do you still say it's osteoarthritis? No. Next slide, please. It is called osteoarthrosis. It is not an active osteoarthritis going on. It is called osteoarthrosis. So we do not give the diagnosis of osteoarthritis at the time. We do not generally give, okay, if the patient is having osteoarthritis, we say it is osteoarthrosis at the time, according to our American Academy of Orofacial Pain. Next, please. So this is our one of a case, 40-year-old female. The patient has a right preauricular pain. So this is the right preauricular. It seemed a little goofy, so we thought we did not have a good pan. So we said, okay, let's take another pan. Next slide. So it was still didn't find it to be a very good pan. I will say the quality of the pan was not good, but she was having too much of pain, and we said, okay, let's take a cone beam CT for this patient. Next slide, please. So this is the cone beam CT of this patient. This is the right side, and this is the left side if you look at this one. So right condyle, definitely some flattening over here. Some erosion is seen over here. If you look at the left condyle, there is also flattening. But sclerotic bone has been formed, sclerosis over here, and some osteophyte formed over here. Next, if you look at this one over here, you will see how bad is it on the right side, and the left side is still, you know, better. So on the right side, it was diagnosed that patient is having an active arthritis going on, and on the right side, and on the left side, it was considered as not an active. It is osteoarthrosis. So, and on the right side, it is osteoarthritis. And because the patient was not in pain on the left side, and even in the x-rays and the CT scan, it was not that, to that point, we say the patient is having there is a sclerotic bone formed on that one right now. So this is the reason of this slide this is the reason to show the difference between osteoarthritis and osteoarthrosis. That was the main point of describing, giving you the example, why we put separating the two terminologies and why it is so different, osteoarthritis and osteoarthrosis. Because when we take random people, if we look at it, when we are screening our patients, when I am in the screening clinic or in the emergency clinic, we are doing so many PANs, and we look at so many PAN X-rays, and so many patients have these arthritic changes, and we do not start saying, okay, patient has osteoarthritis, there is arthritic changes going on, and we start treating these, giving them NSAIDs and everything. Patient should have a pain component present to say that, yes, this patient needs some treatment or something is going on. Next, please. Okay, this is an interesting case. She's my 64-year female patient. She complained about left Tmj pain. Okay, this is her left Tmj. So this patient came that she had an involuntary movement of her jaw, and the jaw moves towards the right side. She's sitting there doing nothing, and the jaw moves towards the right side. And when it moves towards the right side, she does not have it can be a possibility, but usually it has been seen that arthritis changes into osteoarthrosis. When it is active, then it becomes after some years, 1 year or 1.5 years, usually literature say it's a year and a half to 2 years, it changes into arthrosis. The bone forms, sclerotic bone forms on it, and the patient does not have pain. But the changes are still there, and the patient, when the crepitus is still there, all the symptoms will be there, except pain component is not there. So usually it's the other way around. From osteoarthritis, it goes into osteoarthrosis. So I'm telling you, my son, when he was 13, and I saw his PAN, and his TMJ joint was miserable. But maybe his TMJ joint was growing. He was 13 years. It was not fully formed, I will say, 13-year-old. And he did not have any pain or anything, but it was, there were so many arthritic changes in that one. So we got all his blood work done to rule out any kind of, we got all his rheumatological panel done. Maybe he had some kind of rheumatological issues going on, RA and all those things. It was normal. And just to be on the safe side, But then I asked, then we recalled, he plays so much of video games and everything. And when he's playing those games, he's clenching too much. If he's spending 1.5 hours to 2 hours on games and everything and clenching too much, he's putting so much pressure and everything. And along with this social media thing and along with the nighttime clenching probably. So that is causing the destruction of the TMJ joint, but he's not in pain. So he has osteoarthrosis still, but we have seen usually, it's osteoarthritis moving on to osteoarthrosis. But this patient, when her jaw moves towards the right side, so she does not have any contact on, most of the teeth are not contacting. And that makes her, when she's chewing food, makes it so difficult. So she's biting on her tongue, she's biting on her lips, some on her right side of her cheeks, so much. And she was referred to me by her dentist, so because they said we cannot do anything. So, as in US, we are guided by what we call insurances. So we said, okay, she couldn't pay too much about, so I said, let's get a cone beam CT scan along with that. Let's see what's happening with MRI, because she has some headaches and other things going on as well. So I said, let's get an MRI done as well to rule out anything else going on. We send her blood work as well. And she said, I cannot afford a cone beam CT scan because I do not have I cannot spend that much money. I said, okay, let's get an MRI. They refused the MRI for her TMJ joint. But anyhow, for headache, they approved that for her headache. That is interesting. For TMJ, they said, okay, give her a bite guard. I said, what will she do wearing a bite guard when her bite is not in contact? So I had to literally fight with the insurance company, because when the teeth are not touching at all, what will the bite guard is going to help her? Anyhow, thank God we got approval for our headache purposes, and they come to know about, this was the next slide, if you let me know. Move to the another one. Oh, it's not there. There should be one more. Go back, Mariam, back. Okay, I cannot read that one. So they suspected that there is some fluid over there. It's a septic arthritic changes, something septic arthritis. So I talked to my oral surgeon that we need to take her to drain it as soon as possible and send it to the labs to see what kind of bacteria is growing. And I don't know what happened. It's a recent case, and I haven't got the report. So it was interesting thing to see, you know, because if this one, it's on the left side, and if you think about it, the amount of the joint is, you know, destruction of the joint on this side, we always suspect the TMJ joint moving towards the left side, not to the opposite side. And she did not have any kind of fever or swelling or anything going on to suspect there is some kind of septic TMJ arthritis. We did not suspect anything going on. And that has been present for 6 months. And this was interesting. That's the reason, you know, I put this, my case, it's a recent one. So let's see what will be the verdict on this one. And even my oral surgeon did not agree to it, that the patient has a septic arthritis. And let's see. Now we can move it to the next one, please. Next, please. Masticatory muscle disorders. It's a huge topic. So, but we are just going with the basic myalgia. So as we know, there are 4 major masticatory muscles that are, we consider them masseter, temporalis, medial and lateral pterygoids. These are the major 4 we consider, but we also look at for the SCM, then we go with the occipital, paracervical, skin, then traps. So when we are examining our patient, we start with all the way from the trap to all the way to the head, neck region, and our masticatory muscles. So some of the muscles like lateral pterygoids, we cannot palpate them. We do functional tests to see if those are the culprits. For example, lateral pterygoids, when they are the culprits, the patient is having difficulty, or we will say their jaw movements are a little different. You know, they impact differently. So as simple as, next slide, please. As simple as myalgia, we will say it's a pain of muscle origin and affected by jaw movement, function, or parafunction. And replication of this pain is with provocation testing. So tell the patient to, open, close, do some jaw functions like clenching, grinding, or moving your jaw to right and left. So these are certain of the exams we do. Push your jaw against a force, move your jaw in certain way. So we do those kind of functional testing and examine the patient and see if that can, mimic or replicate their pain. So to see if that is the reason of patient's chief complaint. Next, please. So first type is I know this was my fancy slides, and it's not, with PDF, it changes into a little different way. You have to go one more slide. So it can pinpoint. So first is the local myalgia. There are 3 different kinds of myalgia. First is the local myalgia. It is at the pinpoint at one point, you know. That is the local myalgia. Okay, this is the area of pain. So you palpate different muscles. You take 2 fingers or 1 finger and palpate it. So it's a 2.2 pounds of pressure you put on the patient's muscles, like this is the temporalis. You palpate the interior, middle, and posterior temporalis, masseter, superior, and inferior masseter muscles. You go all around your different areas, and you come to a pinpoint area. Oh, this is the muscle. The patient say, oh yeah, this is the area where I'm having pain, Dr. Hasan. So this is the area. So that is the local. This is the local area. This is the pinpoint area patient recognizes. This can be local over here. This can be local over here. There can be 2 different local areas over here. So we recognize it. Okay, this is the area where patient is saying patient is having pain. We diagnose it as local myalgia, or we say, okay, masticatory myalgia. The patient is having masticatory myalgia. So we diagnose them and give the treatment accordingly. Okay. Treatment can be as simple as sometimes we say, okay, just give them trigger point injections over here and see if that can take care of the pain. It's like something they have done, you know, maybe have done a clenching. They might be a stressful event in their life. They have done a little bit more clenching and they might have some painful area. Or it's similar to, like, you know, you're doing exercises, and one day you exercise a little bit more and you start experiencing a little bit pain in your muscles. It's a similar kind of thing. But if it persists longer than that, next slide, please. Now it becomes myofascial pain. So it becomes, the area has a little spread out. It's the same muscle, but it has spread out or more. So there is an area where there are more area that has, they're feeling it more in more area. The patient say it's a tightness. Sometimes I'm sitting doing nothing. It's still painful. When I try to open wide, I cannot open wide because it's became painful, and it's so painful that I'm scared to open wide. This kind of pain can be so intense that, you know, when we have disc derangement, when they have a locked jaw, the patient can open up to 25. But with this kind of myofascial pain, sometimes the patient can open up to 16 mm or even 10 mm. So when I have a patient who said, I'm locked, I said, okay, my students will say, Dr. Hasan, we have a patient. The patient is locked jaw. I said, okay, how far the patient can open? Oh, patient can open, Dr. Hasan, 8 mm, 10 mm. I said, no, it's not locked jaw. It is the muscles. So I know that muscles are stronger than the intracapsular issues, because with intracapsular issue, the joint can rotate. The rotation can happen. Rotation can happen up to 25 mm, 23, 24, 25 mm. Only the sliding, that is affected. But with the muscles, they are so strong. When there is a myofascial pain issue going on, then they are so strong, especially these masseter and temporalis muscles, then they cannot open wide. Then I said, okay, you know, most likely it's the muscle if they can open less than 23 mm. So then the patient is having myofascial pain. Next, please. Myofascial pain with referrals. So what happens over here? The patient is complaining about, they come, oh, Dr. Hasan, I have a pain in my face. So that is the masseter muscle area. And so I start examining. So when I start examining the patients, when I palpate SCM, and when I'm palpating SCM, patient is having pain in SCM as well. And the patient is having pain in masseter muscle as well. Palpating SCM, the patient, the pain is radiated from SCM and comes to the face in the masseter area, or maybe to the TMJ area. So this is called myofascial pain with referral. The referral is coming to the face. So this is very common, especially from SCM, temporalis area. This is very common that the patient is having issues with the trap area. and the pain is referred to the face. So when we are examining, that's the reason we start examining from the trapezius muscles and to see if that is the cause of the pain rather than the muscles itself, muscles, masticatory muscles or the TMJ muscles itself. So this is a very good diagram from Dr. Occlusion. I borrowed it from him. He has these beautiful, it lights up and everything. Sorry, I couldn't show you very good. So the patient is having pain in the trap area, and that is supposedly, I will say hypothetically, the patient posture is an issue. It's a continuous pain. The patient is working, or a dentist, as a student, we work on our patient. Our postures are not good. We are continuously having a pain in our shoulders, and it is going from first order neuron to the second order neuron, and it's continuously, we have a days of pain going on, and these neurons get excited, continuous pain. It's from first order neuron to going second order, and it's going and processed in the cortex as a pain. It got so excited, that the area where we are getting pain information from the TMJ joint or from the temporalis area, that is also got excited. Now, even though the TMJ, there is no pain, there is nothing going on, but the information which is receiving, no information received from TMJ that there is anything going on, that neuron is also getting excited. And that area is also being processed as pain, even though there is nothing going on, but brain is also getting the information. Okay, the TMJ is painful. Or the temporalis area, the patient is having a headache. It's not shown over here, but supposedly, hypothetically, that area is also getting information as a headache. So pain from this area, trap, actual area is trap is painful, but your whole nervous system or this pathway is so excited that the neurons are so excited, the whole pathway is so excited that even though there is no painful event happening in your temporalis area or in your TMJ, but the brain is perceiving that something is going on, and that two areas, the patient is having headache and the patient is complaining about the TMJ joint pain. So the source of pain is the trapezius area, but site of pain is your temporalis and your TMJ. So referred pain, the clinical rule is occurs most commonly among the branches of the same nerve. When it is outside the same nerve, it usually refers up. So from head and neck region, it usually refers up, but from neck region and below, it usually refers down. So that's the reason if you have pain in your spine, the pain goes to your legs and all the way to your feet. But in neck and above, it always goes to your head and up. It goes up. Pain in trigeminal area seldom crosses the midline. It will always stay on one side, never crosses the midline. I will say always, usually. I always put the word usually. Very rarely we have seen, very rarely it crosses the midline. And sometimes we don't know why. So referral pattern is, these are the commonly seen. Splenius Capitis is the face. That is my mentor, Dr. Occluson's favorite muscle. It's a very tiny weeny. Sometimes even I don't know, we can palpate that. So I put them paracervical muscles at the side of the neck. From SCM, the referral goes to the TMJ joint. It goes to the ear, frontal area. From occipital region, it's very common. Patient is having pain in the orbital area, retroorbital area, as well as patient complaining about sinus headaches. From masseter, the pain can be felt in the teeth as well. Sometimes patient comes with a toothache, even though on x-rays and everything, we do not find anything. Our tests, our endodontic tests are negative. And it's always better to check and palpate the muscles to see if the muscles are the culprit or there is some kind of trigger points in those muscles. From temporalis muscles, always check for the posterior maxillary teeth. If the maxillary teeth are painful, check for the temporalis muscles. I will say the other way around. Interior digastric can sometimes cause pain in the mandibular interior teeth. Next, please. So what is the etiology of all these muscle pain? Deep pain input. Supposedly patient is biting on the cheeks. A lot of people have this parafunctional habit of biting on the cheek. This is a input, continuous pain information is being sent to the brain. So it's the same thing. Along with a patient had a recent tooth being recent crown placed. The crown is placed, it's in hyperocclusion, or there is one of the cusp is in higher, the occlusion is not well adjusted, I will say. And what will happen? The patient is biting on it, it's causing pain, and that information is sent to the brain, and the patient will start experiencing some jaw pain. This is one of the reasons. Trauma can be minor, trauma can be major. Sometimes it can be due to emotional stress. Students having a big exam coming up, they are stressed. Their autonomic nervous system is hyperactive right now. So that is the reason the patient is having some pain. As when our small kids, they are stressed out, they cry, they shout. As an adult, we do not cry or shout so much. We keep inside. We eat our emotions, our stresses. When we eat our stresses, what will happen? We have all these different conditions, hypertension, diabetes, sometimes cancers, these kind of conditions, and it affects us in a different way. So these stresses, these anxiety, depression, these kind of things influences our CNS in a different way. And that also impacted us in our muscle activity, our autonomic nervous system, and it can also affect our TMD system as well, I will say. Sometimes it can be idiopathic as well. When we don't know, I will say to my students, when we don't know anything, we can say idiopathic. Along with that, now we say genetic as well. We have, I think some of the literature had pulled up certain genes, and what we are still exploring certain genetic reasons. And we have seen if a mother is having TMD issues, usually they have seen their daughters having certain TMD issues as well. Next, please. Excuse me. So what about occlusion? Does it matter? So we are dentists. We always try to blame and occlusion. If it is an occlusion, we could have adjusted the occlusion and the TMD issues would have gone. And if we look at Dr. Okison's initial researches, so he has done, and initially in 1978, he had pulled up so much of data to look into that what kind of occlusion is the main reason for TMD. So he had come up with 78 different occlusal scenarios where they say, okay, this can be the reason for TMD, but they could not pinpoint into one or even 1, 2, 3 major reasons for any particular occlusal condition that can say, okay, this can cause TMD. So we cannot say occlusion is the main reason. I have given you an example in the osteoarthritic changes, because of osteoarthritic changes, there has been changes in the occlusion. And we don't know if chicken comes first or if the hen came first, or egg came first, I will say chicken or egg came first. We don't know yet. But this is something different. Let's see, next slide, please. So it's a case of a 45-year-old female. She came and she said, where is my bite? I do not feel my bite. It's always changing. So she had a very unusual bite for the past 10 years. So it's getting worse during the last year. And she had because of this bite changes, she had a certain orthodontic treatment done, and some splint she had certain kind of splint. But she was not satisfied with the ortho treatment as well. She stopped the treatment early. And for the past 4 months, she's feeling, because of this bite, she's feeling tired, having this continuous discomfort, and she's not adapted to this change in the bite. Next, please. So she is unable to occlude in her molars. She feels her tongue position is wrong, believes her tongue is getting bitten on one of the side, no jaw pain, no difficulty in opening, closing. And she feels her discomfort is to the no pain, but she feels because she cannot feel her bite is correct. She cannot enjoy the social functions and always having these anxiety issues because of this change in her bite, continuous change in her bite. Next, please. When we examine this patient, so we do all the cranial nerve examination to see anything unusual in the nerves or anything that was normal. She has some tenderness in her trap muscle, and along with some left masseter muscle and spine. C-spine was also a little tender. Patient's comfortable opening was 42 mm. She can open 42 mm, no pain, nothing, no deviation, no deflection. 40 mm is considered normal. She could open 42. That was perfect, good. Some scalping of the tongue and bilateral linea alba, indicating some kind of parafunctional activity. Her occlusion was class 1 molar relation, and she has a simultaneous bilateral contact. All her back teeth were contacting normally. Even with the shim-stock examination, we could see all her teeth were contacting or touching in the maximum intercuspation. She had her x-rays and CT scan from her previous dentist, recent x-rays and recent cone beam CT scan. And according to that, there was certain degenerative changes in her left condyle, but there is no pain on examination in the TMJ, so nothing going on, nothing extraordinary. There can be just slight degenerative. It's not that, I will say, we can see it in a lot of our patients, mild changes going on. Next, please. So what was this patient is having? We call is occlusal dysthesia, or we can say the patient is very hyper aware about her occlusion. Phantom bite, there are different names for this. Uncomfortable occlusion, occlusal neurosis, positive occlusal sense, positive occlusal awareness. And for the diagnosis for this kind of condition, the patient should have uncomfortable bite sensation, which should be present for at least more than 6 months. And there should be no change in her occlusion, no change in her any pulpal issues, no endodontic treatment, nothing new has happened, no periodontal issues, no muscle or temporomandibular joint disorders. So she did not had any kind of those ongoing, that kind of things going on. And no functional impairment. She can open wide, she can chew her food normally, except that she said she's biting on her tongue, possibly at nighttime. She had some parafunctional habit present because of on her the teeth marking on her tongue and linea alba, bilateral linea alba on her buccal mucosa. Next, please. Which can be attributed to her anxiety. So what is, according to our systematic review that was done on 2007, there were 13 reports, 37 cases. According to that one, the mean age of the patient is 51.7 years and is more prevalent in females as compared to male. And it usually started after a certain kind of dental treatments, usually some kind of restorative work, some occlusal adjustment, extraction, ortho, or certain splints. Even though after all these treatments, the occlusion is good, the patients start experiencing that their bite is not balanced, or there is some, their teeth are moving, or they feel off, the bite is not good. Next, please. So the symptoms are premature, or sometimes the contacts are premature, or they feel that they are not contacting. They feel that when they are moving the jaw, they are premature or slight excursive interferences. Bite is shifting, bite is sliding, bite is off. The The teeth are moving, gums are sinking. So they have all these kind of different things going on, or they believe that the teeth are always moving, it's moving out or in. So this is called occlusal dysthesia, unusual sensation of their occlusion. So psychological aspect, common characteristic found in most patients is functional impairment. So, and most of the patient have some component of anxiety, depression, somatoform disorder, and obsessive compulsive personality disorder. So, or they are more aware of their bite. So that is also obsessive compulsive personality disorder. Next, please. So what causes it? Is it certain kind of psychiatric disorder? Or is it some phantom phenomenon or neuroplasticity? Or alteration in proprioceptive signals? So we don't know yet. But having said that, it can be a possibility. So we had a patient. So she used to feel that in her ear, she had the sensation that there is some kind of insect or something, or she had a sensation that she's always scratching her ear. So that is, she was not in pain. She came to us, we looked at, there was nothing. And this is called, that is also dysesthesia, unusual sensation. And there was another patient, she had an implant placed on number, I think so it was 28. She has a very nicely integrated or nicely placed implant. She had a crown on top of it. And after that, she had a sensation that itching sensation in that area. Itching to the point she cannot tolerate the implant. She got it removed and there is a big hole. Despite getting it removed, she still had the sensation of itching in that area. So that is also dysesthesia. So this can also be dysesthesia. This is, and I will not say both of my patients, because both of my patients were my patients. I remember those patients, and I had this kind of patient as well. And my occlusal dysesthesia patient had some depression and anxiety component, and she was more aware of her bite. But my other two patients, they were, I will say, did not have a depression and anxiety component because we got it analyzed as well. But, they have this unusual sensation, and which is beyond their control. So how to manage these kind of these patients, that becomes the challenging. Nobody wants to listen to them. Next, please. Because they will say it's all in your head. So how you manage them? So this is a proposal based on the theory. They say psychotherapy drugs, EMG biofeedback, tell them some physical therapy activities. Sometimes they said exercises. Tell them to avoid checking their bite, change their focus. Then they give them some exercises whenever they have that urge to check their bite. Tell them to give them the exercises so they focus on something else. Providing them some education and certain medication like SNRIs, or then there are literature say as NRIs, then there are certain anticonvulsants as well, certain splints as well, then tricyclic antidepressants as well. So there are different kind of medications, and most of them have been good on these medications, except for my ear patient, when she has that crawling sensation and itching sensation in her ear. She said, I can manage this sensation. It was just, I want to rule out anything else going on. So she said, I can manage it without medication. Unless something changes, I think I'm good with it without taking any medication. And that's her choice. But rest of them are usually on medication, and that helps them with this kind of sensation, I will say. Next, please. So when you have this kind of patients, as a dentist, do not try to fix their bite. It's not ever going to help them. my mentor helped me to understand these patients, and he taught me not to change their bite. And he made the mistake with one of my patients. So my patient was a 45-year-old female. So she had this sensation, this occlusal dysthesia, that his bite is always changing. So she came one day and she feels this side is contacting first, and next time she came, this bite is contacting first. So she was given on tricyclic antidepressant. We had a appointment made with clinical psychologists, so they were helping her. She was good. Till she was seeing the clinical psychologist along with her medication, she was doing good. She stopped taking that one, and then she came back again. And then she said, okay, now I still started feeling that my bite is again shifting. My teeth are contacting on it was the left side, I believe so. First, this is the particular one, it is hitting first, and that's the reason I cannot contact. She was doing fine, and Dr. Okison said, okay, let's do some adjustments. I said, Dr. Okison, you taught me not to do adjustment. He said, okay, we will do just a little bit. And we got a paperwork signed for her, special consent for these patients. And I said, I will not do it, Dr. Okison, because she was doing fine with the medication. I do not feel comfortable doing it. He said, I will do it. I said, okay. And he did the adjustment. And from that day onward, she was crying and calling the office that her bite is worse than it was. And this is what happens with these patients. And I want an ortho treatment done. And my bite has worse since this adjustment. And he did not do any adjustment. He just touched the burr in that area, and it was just a finishing burr, and he just touched a baseline. And Dr. Okison came to me. He said, Amna, you were right. I should not have touched her teeth. And so we sent her to our ortho department for consultation. She said, no, I want to go to outside somewhere. So we made the appointment over there. And along with that, we called her and gave her medication again, appointment with the clinical psychologist again, and gave her the supportive therapy, what we can do from here, our side, and appointment with the orthodontist so they can work on her bite. But there was nothing to do with her bite. Her bite was good. So this is my advice for all the dentists, as a dentist, that do not try to fix the bite for these patients. It's not going to work for them. And that's it. Thank you. Any questions for me?
Thank you very much, Dr. Hasan, for your interesting and informative lecture. It was very informative. And dear audience, if there is any question, please let me know. We have one question. How do we assess stress in our patients?
There are so many questionnaires online. We always check for the medical history, and there are questions we can ask them, open-ended questions, close-ended questions. So I usually ask them, anything going on. They will say, okay, the pain started on blah, blah date. And I said, what were you doing? What was happening in your life at that time? Anything particular going on. So if they give me the answers, that's good. And usually my patients tell us over here, that, at the time this was going on. And it's important part of about their pain, because if they are in so much pain, they usually tell you. Over here, they tell us, at the time, I was going through my divorce, or, at the time, Dr. Hasan, at the time I was having, my parents were sick at the time. I'm giving you, or my exam, or my job is very stressful. And, and the pain started at that time. Or there are certain questionnaires. If you go online, I can send you I can send some questionnaires online to Mariam about those ones. anxiety, depression, and those kind of questionnaires. It's standardized questions. You can give it to your patients and they can fill it out, and you can go from there and analyze from there if something is going on with them. If patients are not comfortable giving answers, you can give them questions and you can assess your patients from there.
Okay, and another question is that what medicine do you recommend as a muscle relaxant prescription?
Muscle relaxant is the first line of treatment is, if we are giving it for 2 to 3 weeks, is cyclobenzaprine. Is the first, you can give that. And it depends upon if it's a local myalgia, then we can give that one. If it is like myofascial pain, it becomes more central component. Then we go with mostly the muscle relaxants which act centrally, like tizanidine, baclofen, those kind of muscle relaxants. If the patient is having musculoskeletal pain, if they are having headaches, if they're having sleep issues, they're not sleeping properly, so then we come up with the medication like tricyclic antidepressants like amitriptyline. So it's a once a day medication. It's at a bedtime. We start with 10 to 20 milligram at bedtime, and we'll go from there. So these medications, we can give them for longer duration of time. Some patients, they need it, for 6 months, maybe a year. So depending upon what other things you have found in your examination, if you have found the patient is having headache, you have found the patient is having sleep issues, because sleep also plays a very important role in their jaw pain and headaches. So we prescribe accordingly. But as far as local myalgia is there, so we can always go for cyclobenzaprine if we are going for a shorter duration of time.
Okay, and another question was that does the osteoarthrosis become osteoarthritis later?
I think I gave that. Arthritis becomes osteoarthrosis usually. So it's we haven't seen like our osteoarthrosis switching to osteoarthritis.
Okay. Dear audience, any other question? Okay. Dr. Hasan, thank you very much for sharing your knowledge and your experience and accepting our invitation and joining us. It was very useful for us, and I hope we be your host in Iran as soon as possible. Thanks a lot.
Thank you for inviting me. Thank you. I enjoyed it. Thank you, Mariam. Thank you, everyone.
You're welcome. Have a good time. Thanks a lot.
You too.